How many times have you heard that health and well-being are simply a matter of individual choice? Willpower, that it's all about personal responsibility.
Yeah, it's everywhere, isn't it? But today, we're doing a deep dive into some really interesting research that challenges that whole idea.
Great.
We're looking at two concepts: care infrastructures and health practices. And basically how changing habits isn't just you, it's actually a collective effort. Involves people, yes, but also non-human things too.
Sounds intriguing. So what's the source for this deep dive?
It's a qualitative study from Italy. It looked closely at a workplace health promotion program, WHP, for sedentary workers, trying to reduce risks for things like type 2 diabetes, cardiovascular disease.
Got it. So let's unpack those terms first. Care infrastructures.
Yeah.
What does that mean exactly?
Right. Think of them as the sort of tracks that care runs on. They're these pervasive, enabling resources. It's a whole system, people, sure, like professionals, but also knowledge, routines, and everyday objects, even things like, cupboards, shelves, phones. Like a doctor gives you a prescription. That piece of paper, or maybe the app reminder, becomes part of your home. It actually changes how you use your space, your daily rhythm. It's embedded.
Right, I see. So the infrastructure is this sort of environment, the setup.
Yeah.
What about health practices then? Not just individual actions.
Exactly. The research defines them differently. Not just behavior, but locally situated and composite actions. They emerge from interactions in that specific context using that infrastructure.
Yeah.
It's about collective doing, not just self-care.
So less like running a solo marathon.
Yeah, much more like a relay race. You've got teammates, maybe unexpected equipment, the track conditions change. It's dynamic.
Okay, so with those ideas, let's look at this specific workplace health promotion program. How is it supposed to work?
Well, on paper, it looked pretty straightforward. Risk assessment questionnaires, you meet with a physician, a lifestyle counselor. Then there were digital tools, a mobile app for diet tracking, fitness trackers for steps, and some workplace stuff like a gym, seminars. Pretty standard, really, based on that behaviorist idea that you just need to change individual actions.
But reality wasn't quite so neat, I take it.
Not quite. A lot of the participants were what the study called the worried well. They were generally healthy, actually quite surprised to be labeled at risk.
Oh.
But that label, that risk assessment, it kind of made them ready subjects, suddenly open to these health interventions.
Interesting. So how do they actually use these intended care infrastructures, these tools and people?
Well, take the mobile app for diet tracking. It was meant to be a key tool.
Right.
But workers found it, too general and honestly extremely time-consuming. So it ended up being pretty peripheral, not used much.
Okay, so the app didn't quite land. What about the fitness trackers?
Those were different. People got quite creative. They appropriated them, used them in ways the designers probably didn't intend.
Like how?
Well, some used it almost like a reminder, a memo for their diet, not just for steps. And others actively avoided certain features, like the sleep monitoring, because they wanted a bit of freedom from being tracked constantly.
So they adapted the tech to fit their lives, not the other way.
Exactly, which is appropriation. And the people part of the infrastructure, that became huge.
So.
Health practices really became collective. People involved their families, like a mother walking with her son just to get steps in, or a couple deciding to walk to a soccer match instead of driving.
Makes sense.
Even colleagues influence things, like making healthier choices at lunch together. And this was vital, especially for female workers who the study noted were often juggling, 3 shifts, their job, work at home, and now this fitness effort.
Wow, yeah.
The lifestyle counselor was key there, helping them figure out how to weave activity into family duties, not just add another burden. So the practices weren't rigid, they were semi-stable, constantly being tweaked, repetition without repetition, the researchers called it, to fit daily life.
And I gather they sometimes modified the program itself, repairing it. The study says.
Yes, exactly. Tinkering. Like someone might use their own phone's step counter instead of the official tracker. Or maybe they skipped the program's gym sessions to go to a Zumba class they already loved. Or followed a different diet plan they preferred, like the zone diet.
Making it their own.
Right. And then there was also putting aside, temporarily suspending the health practices when they clashed with other really important social things. Having cake with friends at a birthday or enjoying wine at a political group meeting.
The things that make life enjoyable, even if they aren't healthy on paper.
Precisely. Those social rituals are vital for relationships, for feeling good, which is also part of health, right? One worker put it perfectly.
Yeah.
If the doctor tells me you have 6 months to live if you don't stop eating eggplant parmesan, then I would probably stop. Until then, some things are just worth it.
That really highlights the tension.
It does. And pulling it all together, the study points to three big insights. First, multiplicity. This idea that there's one single answer, one right way in health promotion, it's kind of an illusion. Real-world care infrastructures are multiple, diverse, adaptable. They need to be durable, not rigid.
Okay, multiplicity. What else?
Second, hierarchy. The program was sort of designed for flat cooperation between tools and people, but in reality, the human counselor became central, the real guardian of the process.
Ah, so the tech became secondary.
Often, yes, more peripheral, which kind of reinforces the importance of that human connection, that guidance.
Interesting. And the third insight?
Affect, emotions, they're hugely important. Things like anxiety or surprise after getting that at-risk result, that pushed people to get involved initially.
Right.
But then positive feelings, pleasure from activity, the warmth of doing things with family, the support from the counselor, those sustained engagement. And conversely, affect also drove that, putting aside the need for social connection, even if it meant feeling a bit sad or guilty about pausing the health practice.
Wow. So it's far more complex than just deciding to eat better or move more.
Absolutely. It's this dynamic interplay. People, objects, emotions, routines, social ties, it's all woven together. It's not just about individual willpower.
So wrapping this up, what's the key takeaway for someone listening?
It really challenges us to think differently. It suggests that changing habits is a complex collective effort. It depends heavily on the care infrastructures around us, the tools, the people, the environment, our feelings.
So maybe the question isn't just, how strong is my willpower?
Exactly. Maybe a better question is, when you think about your own goals, what infrastructures, human and non-human, are actually supporting you? Or maybe getting in the way? And just acknowledging that complexity, how might that change how you approach things?
It definitely makes you reconsider that whole personal responsibility line, doesn't it? Maybe it's less about pure self-control and more about navigating this really interconnected reality we all live in.
I think that's a great way to put it.